The PKD Foundation is monitoring the unprecedented COVID-19 pandemic, and we want to keep the PKD community informed. My name is Nicole Haar, and I'm the Director of Community Engagement at the PKD Foundation. The PKD Foundation does not offer medical advice, and the information shared during this webinar is not intended to be a substitute for consultations with your healthcare professionals. Care and treatment decisions related to your health must be made in consultation with your healthcare team. Joining me is Dr. Patrick Dean, and he will be addressing concerns submitted by the PKD community about transplantation. Dr. Dean is the Surgical Director of the Kidney Pancreas Transplant Program and a consultant and associate professor of surgery in the Division of Transplantation Surgery at Mayo Clinic, Rochester. He received his undergraduate degree from Princeton University and subsequently graduated from the University of Alabama School of Medicine in Birmingham, Alabama. He completed his general surgery residency and fellowship in abdominal transplantation surgery at the Mayo Clinic in Rochester, Minnesota. He was appointed to the faculty at Mayo Clinic in 2006. In addition to his clinical duties, Dr. Dean is the program director of the Abdominal Transplantation Surgery Fellowship Program and co-chair of the Enterprise Transplant Informatics Workgroup. Dr. Dean's clinical and research interests include kidney and pancreas transplantation, preemptive kidney transplantation, living donor kidney transplantation, transplantation for polycystic kidney disease, and antibody-mediated kidney graft injury. He is a fellow of the American College of Surgeons, as well as a member of both the American Society of Transplant Surgeons and the American Society of Transplantation. He has been a member of the Membership and Professional Standards Committee of UNOS and the Fellowship Training Committee of the American Society of Transplant Surgeons. Currently, he is the chair of the Program Accreditation Committee of the ASTS Transplant Accreditation and Certification Council. In addition, he serves on the Clinical Policy Board of LifeSource and the Kidney Pancreas Committee of LifeSource. Dr. Dean, I'm going to turn this over to you.
Well, thank you, Nicole, for the very kind introduction. And it's truly a pleasure this morning to talk to the PKD Foundation and their members about kidney transplantation in this era of COVID-19. By ways of disclosure, I have no commercial interests in this presentation. I do, however, have a couple of additional disclosures. As most of you will know, the pandemic of SARS-CoV-2, the virus that causes COVID-19, is evolving rapidly and very differently across different areas of this country. Right now, we have very few data regarding COVID-19 and transplantation. There are some small reports out of countries like China where this originated, but they're very small numbers of patients that have been involved, and the data are pretty scarce and sketchy. So what we're going to discuss today is based mostly upon educated opinion or opinions, and I want you to realize that many of these opinions may change over the next few weeks as we gain more real data about transplantation in this pandemic situation. I thought what I would do is go over some common questions that we've encountered at our transplant center, as well as those submitted by members of the PKD Foundation in a brief survey before this webinar. One of those, and probably the most common question we get, is have transplant operations been postponed or canceled in the United States? And the short answer to this is yes, but I'll describe some caveats to that in a second. Depending on where you live in this country right now, you're experiencing really varying degrees of COVID-19 disease and infection. And so some hospitals, especially those on the East Coast, are very overwhelmed. So they have no resources to do anything other than take care of patients with COVID-19. And so their ICUs are full, their doctors have been repurposed or reallocated to different areas, practicing in areas that they don't normally do to take care of ICU patients or other hospitalized patients with COVID. However, there are a fair number of hospitals that are preparing for a surge. And so a common scenario across the country was that hospitals kind of put almost a total halt on transplants, but not necessarily total, in order to kind of assess the situation and see what their particular area would encounter with COVID. So as many of you have seen on the news, if you have turned that on, hopefully you're not doing it too much because that can be very disconcerting. But if we start at the beginning of March, really there were only about 70 cases reported in the United States at the beginning of March, basically in the middle of this graph. But going up until earlier this week, there are many, many cases that have been confirmed in the United States. So in the last 6 weeks, really a large number have been encountered, to the point where it's over 200,000 now in the United States. And so if you keep that time frame in mind, basically early March until now, we'll now look at the number of deceased donors that have been recovered across the country. And on the number on this x-axis is the number of donors that have been recovered, shown in the green line. So if we start on the left-hand side of the axis back in January, we'll see that around 240 or so were done every week back then. There was a bit of an increase up until mid-February. And then again, starting in the early part of March, things really declined to the end of March, when there were only 161 donors recovered in that last week of March. And as you might expect, the number of transplants, and this is all transplants, not just kidney transplants, but dating back the same time frame, the green line you see surged a little bit when the number of donors recovered increased, and then it has, as you would expect, decreased through the last week of March and the first week of April. On the kidney transplant side, the number of living donor transplants, and this is in early to mid-March, really took a decline, going from about 140 to 150 a week down to only 16 performed across the entire country in the first week of April. And a lot of that was related to the concern, one, of what transplant centers and their hospitals were going to encounter with COVID-19, and two, and justifiably so, I think, the concern about bringing a very healthy donor into a hospital and perhaps exposing them to COVID-19 when they're having a very elective operation. But the counter argument to that is they're helping someone who's on dialysis, maybe running out of dialysis access, or in certain cases, they're trying to avoid dialysis altogether. So the timing of these transplants becomes important. But certainly the number of transplants and kidney transplants, especially across the country, have decreased. Another question we receive a lot is, what is the risk of acquiring COVID-19 for me or my donor if we proceed with a transplant? And the short answer is that depends. And I think that depends mostly, again, on what is the pattern of COVID-19 exposure at the transplant center. Where is it in the country? What is its tally of COVID cases been? And then secondly, what screening measures are in place at the time of transplant at that transplant center? We have a couple of different types of screening tests that you've heard about probably a lot on the news. One is a test that with the swab in the nose that looks for the actual virus. And so it's what's called a PCR test. And that looks for RNA material of that virus. So that implies that somebody has an active infection. One of the things about that test is it's not perfect. It can be, and we'll talk a little bit about later, but it can be negative when the patient actually has the virus and potentially could transmit it to someone. The other type of test we have is what's called the antibody test, and that looks for antibodies, which are proteins that develop after we have any sort of infection, influenza, common cold, other viral infections. Our body makes antibodies against these viruses. And the presence of those antibodies in the blood, which are detected with this second screening test, would imply that we have had exposure to the antibody or to the virus and gotten over that virus. One of the limitations of that test is it doesn't, for one, necessarily imply that we can't become infected again. And two, it also, if that antibody test is positive, which we should think is a good thing, it doesn't mean that we can't transmit the virus to somebody else. We could have a positive antibody test, but still have virus in our blood. So as these antibody tests are becoming more common and being rolled out to more and more laboratories and centers, many centers are doing a combination of the two. So we might do a nasal swab looking for the virus in the blood and the antibody test at the same time. And the best situation for that test, that combination of tests would be we had a negative virus test with the PCR via the nasal swab, and then a positive antibody test, meaning we had been exposed. But there are lots of combinations, and again, neither of those tests is perfect for giving us 100% assurance that the patient is either immune to this condition again or can't transmit it to someone else. So this slide, which was pulled off of Google Maps earlier this week, shows the number of cases in the United States by area. And so any blue dot is the size of the blue dot represents how many cases in that state have been diagnosed. And the diagnosis was done with the PCR test on the nasal swabs. Those are the tests you see at the drive-through testing centers with all the long lines at them in many places. So if you look at the East Coast, places like New York, and this isn't centered on a city per se, it's centered on the state. And so places like New York and Connecticut have had huge numbers of cases, as have New Jersey. And again, this has changed even since I downloaded it 3 days ago or 2 days ago. But you can see places like Minnesota, where I live, are relatively not safe, but we certainly have fewer cases. The Dakotas are pretty well free of the virus relative to the East Coast, but not free totally. The other thing is this also gives you a good sense of where people live in the United States. And so obviously California has a lot of people, the East Coast has a lot of people, but when you get to the Mountain West, places like Montana and Wyoming just don't have that many people living there, or nor do the Dakotas. And so their number of cases, as you might expect, will be smaller. So a lot of the risk of acquiring COVID at the time of a transplant, I think, depends on the prevalence of that disease in this area you're getting transplanted. And so just by logic, you would be more likely to be exposed to the disease in a place like New York than you would in New Mexico. And so that has to be taken into account. And this is, again, some of the places where, especially on the coast, where those hospitals are overwhelmed with the number of COVID-19 patients and aren't able to provide life-saving transplants in many cases, just because of the burden of the disease. Another question we've received quite frequently is, can I acquire SARS-CoV-2, again, the virus that causes COVID-19 disease, from a deceased donor? And again, that depends, but it's not very likely. Many, if not most, of the organ procurement organizations, which are are also called OPOs, and they're the organizations that facilitate deceased donor recovery and transportation of organs. Most of those are testing the deceased donors for this virus, either with that swab test we're talking about for the PCR on the virus RNA, or sometimes a more invasive test is done on the donors where they take secretions from the lung with a bronchoscopy and then do the testing on that sample. And that sample might even be a little more reliable because it's from the lung, which seems to be an area this disease affects quite a bit. So most organ procurement organizations are testing every donor. I would say everyone that I know of is testing donors that have any inkling of being exposed, meaning they had symptoms like a fever or a cough or other symptoms of COVID-19 before they passed away. But many are doing this in a very timely fashion, actually, so that it doesn't delay the procurement much at all these days, because the tests have become more rapid. However, as we talked about before, the test still can be negative even if the donor is infected, and that's what we call a false negative result, meaning the patient who was tested actually has the disease, but the test came back negative. That's not common, but can happen. And I think every center that's doing deceased donor transplants now, or living donor for that matter, will talk to the recipient about that potential risk. Even though it's small, it's still something that the transplant candidate should be informed about and should know about. However, to date, with this testing, and this is also implying that no one has actually used organs from a COVID positive donor, which is what I'm pretty sure is the case based on a lot of the discussion boards and webinars that have been going on in the transplant community. Most people are just refusing to transplant organs from COVID positive donors, which I think makes sense. But no case of donor transmission, meaning the donor passed it on to the recipients, have been reported to date. Another very pertinent question we've received is, what should I do to stay healthy in preparation for a transplant? And I think in this situation, what applies to the general population certainly applies, if not more, to people waiting for a transplant. Many people waiting for a transplant have other existing conditions such as heart disease, diabetes, and may be more likely not to fare as well if they do contract COVID-19. So I think it's very important for us all to follow the guidelines from the CDC, your state, and even some local authorities have issued specific guidelines regarding face coverings as well as social distancing. Those have been shown to slow the spread of this virus. Areas that weren't able to initiate or implement these measures as early as others were certainly affected more with the virus than the ones that were able to establish, separation of people, really, since that's how this virus spreads. I'm not here to talk about the politics of that, but certainly it does work. It's had tremendous effect or impacts on the economy and people's well-being, but from a pure virus standpoint, it has worked. So make sure to follow those. Make sure you wear a mask. And if you do begin to experience any symptoms, contact your primary care provider or your transplant coordinator. Either of those should be able to help you arrange testing. And testing varies about how it's done across the country right now, whether it's at a clinic or a lab, or whether it's at one of these drive-through type testing facilities. But either your primary care doctor, your nephrologist, or your transplant coordinator should be able to assist you in obtaining testing. And of course, it's easy for a lot of us to get overwhelmed with this virus, but be sure to maintain good attention to the rest of your medical conditions. Fortunately, for patients with PKD, they don't often have as many coexisting medical conditions as patients with, that have been type 1 or type 2 diabetic for many years, for example. But our PKD patients tend to be pretty healthy otherwise, but certainly keep a really good eye on your blood pressure, your weight, and anything like diabetes or heart disease that you happen to have. Make sure you're taking your medicines, make sure you're keeping a good eye on those conditions to stay as healthy as you can in case a transplant does become available. And that's generally good advice in the absence of a pandemic as well. Another question, getting a little bit to the other side of the transplant. So assuming that you've had a transplant, what should you do? I think this boils down to really good common sense. I've often told patients we don't do transplants so that people have to live in a bubble, but this might be an opportunity or a time when someone might need to be in a bit of a bubble. Certainly, you again want to follow the guidelines of the CDC, your state, and your local authorities in maintaining social distancing and using a mask. Normally, kidney transplant recipients don't often routinely wear masks unless they're around somebody that's ill. But I think for now, you can assume that many people that we don't know about are ill. So I would wear a face covering. in order to, and hopefully the people around you are doing that as well to prevent the spread. Another common sense thing is if you think someone has been exposed to COVID-19, then I would maintain a safe distance from those people. I think a 2-week period is probably sufficient, and that's what most of the recommendations would say. I think that it's not foolproof, but certainly 2 weeks would be a reasonable amount of time. And certainly if anyone that you know or family members or people at work have been diagnosed, then you should isolate yourself from them. And that can be very hard. Many of us rely on other people to help take care of us after a transplant. And so coming up with some creative measures to make sure that you get the care you need after the transplant will be very important. And it's really hard to stay away from family members. I've been trying to do it in our house, and it's quite difficult. You run into them a lot more than you think. And of course, please let your transplant coordinator or your primary care doctor or your nephrologist or whoever's providing most of your medical care following the transplant know about any symptoms that you've developed. The most common symptoms of COVID-19 are fever, which we won't always see in our immunosuppressed patients, but even in the small numbers that have been reported, about half the people had a fever. Diarrhea can be a common symptom of COVID-19. Of course, there are many reasons that people have diarrhea as well, not always related to COVID-19. It might be some of your medicines or even just a regular gastrointestinal illness, which are very common. The other thing that we look out for are things like what we call myalgias, which are muscle aches. Kind of feels like you might have the flu, and that's another possibility too. Influenza causes very similar symptoms as does COVID. But any of those type of symptoms, I would reach out to your transplant coordinator or your primary care doctor or your nephrologist to assist with obtaining testing and any recommendations they might have. The other thing that's very important for people who've had a transplant is to make sure you have your medicines, especially your immunosuppressive medicines, any medications you're taking for heart disease or blood pressure or any other chronic conditions. There's shipping routes and logistics have been impacted by COVID-19. They're still up and running. The FedEx truck comes through my neighborhood twice a day, it seems like, but things may be delayed, so don't wait till you have just 2 or 3 Prograf tablets or capsules to call in and get the prescription. Try to think ahead and make sure that you have at least a month's worth of medications of all your medicines on hand. Again, don't forget about those other health conditions. Don't be so focused on COVID that you forget to take your blood pressure medicines or contact your physicians or coordinators if you're having problems with blood pressure. And another very important thing, I think, which is starting to get a little more attention, and this probably relates to people waiting for a transplant or who've had a transplant both, is to really try to be resilient in this time. There's a lot of uncertainty, there's a lot of anxiety, but try to maintain as sort of a stable mental balance as you can, knowing that you won't be able to do that. None of us can all the time, but really try to maintain your mental health and take care of that aspect of your overall health as well. The last question we'll talk about this morning is, are there treatments for SARS-CoV-2? Again, that's the virus that causes COVID-19. And the short answer is no. There are no FDA-approved treatments for this virus as of this morning. There are many treatments that are being tried. Right now, there are over 100 compounds that are being tested for how well they can slow down or even potentially cure this virus. But right now, there are no FDA-approved medications. There have been many that have been talked about in various news outlets, but there's no trials to show that they're really effective. Some of the more common ones you might hear about are hydroxychloroquine, which is a repurposed drug used for either malaria or lupus or arthritis patients. That's been in the news quite a bit. It may have some efficacy It's being used quite a bit in that hope, but there are no trials really showing that it's truly efficacious. Other drugs that are being used are drugs, one's called remdesivir, which is an antiviral drug that was developed to help combat the first SARS virus, SARS-CoV, as well as the Ebola virus, which affected, fortunately, a much smaller number of humans than this current virus. But the trials, the early trials have shown some promise in very sick people. This is the kind of medicine that you get when you're in the ICU, maybe on a ventilator as well, to help slow down and let you recover. It doesn't cure the virus, but it can treat the virus and allow the rest of your immune system and body to recover. There is no vaccine for this virus currently. Vaccines, unfortunately, do take a lot of time to develop, both to develop and then to test in a sufficient number of patients to show that it works. And that takes a lot of time. There are a lot of people working on vaccines, both government agencies, private agencies, as well as corporations, drug companies, and vaccine corporations. However, the latest I've heard is that probably a vaccine would be about 1.5 years or 2 years away until it's widely available. That's all I have for you this morning. I know many other questions may exist or may come up over time. My email address is on the screen there, and I know that all of you should realize that your transplant centers are thinking about you. They haven't forgotten about you. They're going to try to get your transplant performed as soon as possible. Many centers, again, based on discussion boards, contact with colleagues, as well as some webinars given by the American Society of Transplantation, are planning to resume living donor transplantation in the next few weeks to months. Many are still doing deceased donor transplants right now, but they haven't forgotten about you. Your center still knows you're out there. Feel free to contact them. Feel free to contact me anytime. I'm pretty good about replying to email if you should have any questions that haven't been answered by this webinar. But thank you again for the opportunity to talk to you, and I wish you the best in this very uncertain time.
Thank you, Dr. Dean, for responding to the questions and comments submitted by the PKD community. We appreciate the information shared about how transplantation may be impacted by the global pandemic. The PKD Foundation appreciates the opportunity to provide you with the best education possible. Please take a moment and complete the brief survey included with this recording. We appreciate your feedback, and your responses will be used to develop additional resources and programs in the future. When you complete the survey, please include additional topics that you would like for us to address in future webcasts. If you have questions you'd like to directly ask the PKD Foundation, please email us at pkdconnect@pkdcure.org, and a member of the PKD Connect team will get back to you. On behalf of everyone at the PKD Foundation, thank you for watching this recording.